Hello everyone, my name is Katherine Arango and today I will be presenting on the epidemiology, surveillance and control of HIV/AIDS in South Africa. As an epidemiologist and public health professional, I have seen firsthand how HIV impacts communities and healthcare systems. South Africa is a powerful case study, not just because of the numbers, but because of the lesson it offers in resilience, policy, and the social dimension of public health. As of 2023, South Africa has around 7.8 million people living with HIV, the largest number in one's country. This presentation will walk you through the context of the epidemic, including the country's geographic and health system, its HIV history, surveillance efforts, ongoing barriers, and what works. I will conclude by recommending a community-based model to strengthen prevention and care, especially in rural and underserved areas. South Africa is a diverse and expanded country with over 62 million people in significant urban-rural divisions. Two-thirds of the population lives in the urban centers like Johannesburg and Cape Town, but millions still live in rural provinces where access of healthcare is really limited. Despite being an upper middle income country, South Africa has one of the highest Gini coefficients in the world, 0.63, highlighting deep income inequality. Unemployment is also a major issue, especially among young people. These social and structural factors significantly impact how people access to HIV preventions, testings, and treatment. Compared to neighboring countries like Botswana, Zimbabwe, and Mozambique, South Africa has more health infrastructure and international fundings. Botswana, for example, has achieved a higher rate of treatment coverage and virus suppression. Mozambique, meanwhile, struggles with political instability and weak health system. South Africa has resources, but the epidemic is more widespread, especially among young women and rural populations. This contrast shows that resources alone are not enough. Targeting policies, community trust, and equality in service deliverance are essential. HIV first appeared in South Africa in the early 1980s, initially among the white gay men, but also spread into a general population. A major setback occurred in the 1990s when government leaders, including President at the time Mbeki and the health minister, questioned the link between HIV and AIDS. This denial delayed access to life-saving treatment. It took pressure from civil society, especially the Treatment Action Campaign, and it forced policy change. By 2004, South Africa began to offer treatment in public clinics. That movement likely saved hundreds of thousands of lives and laid the foundation for today's response. Surveillance is critical to tracking and controlling the HIV. South Africa uses an intentionally clinical survey to monitor prevalence among pregnant women, along with National Health Service led by the HSRC, which is in the clinical in the country. These tools provide population-level data on infections rates, risk behavior, and treatment updates. Clinical data from systems like DHIS monitor treatment, coverage, vital suppressions, and patient retention. Together, they help public health officials making informative decisions, and tracking progress towards global goals like targeting new facilities and new communities. Despite its strong system, surveillance in South Africa still misses key populations. Men who have sex with men, sex workers, transgender individuals, and people who inject drugs often fall outside the scope of traditional data collection due to stigma and fears and criminalization as well. Rural communities are also underrepresented, and mobile units help bring these gaps by using community-led approach to gain trust and gather reliability data. I have seen similar efforts work in Latin America and underserved USA communities as well, where the grassroots outreach is essential. As of 2023, HIV prevalence among adults of age of 15 to 49 stands at 13%. There are about 160,000 new infections per year, and although 70% of people living with HIV are in treatment, only about 72% achieve the viral suppression. HIV in South Africa is generalized, meaning it affects all population groups, not just a specific risk category. This widespread national makes the epidemic hard to control, requiring a multi-sectoral approach that includes not just healthcare, but education, housing, and economic support. Young women are the most vulnerable group. Women aged 15 to 24 are three times or more likely to be HIV positive compared to their male peers. This is a driven by gender-based violence, poverty, transactional sex, and unequal power dynamics. Many of these women lack access to treatment or prophylaxis or productive health services. These are not just a health issue, there are social justice issues as well. Reducing new infections means addressing gender inequality in all levels of area, even in the social level. Some of the structural barriers of HIV care in rural areas are often limited by long distance to clinics, lack of transportation, and understaffed facilities. Stigma and misinformation also prevents people from getting tested or seeking treatment. High unemployment and poverty leads to treatment interruption or non-adherence at all, especially when people must choose between food or medicine. This structural issue must be addressed with the community center and policy-driven interventions. There is hope on treatment access as expanded significantly, and public education campaigns have helped reduce stigma and encourage testing. The number of new infections has decreased steadily since the early 2000s. Community outreach programs such as peer education and home-based care models have proved to be effective. These efforts have shown when prevention and care are local, respectfully, and consistent, they can work even in the high burn of settings. My public health recommendation is to expand community-based HIV prevention centers across the South of Africa. These centers will integrate testing, treatment, prophylaxis, counseling, and job training. The goal is to address both the medical and social drives of HIV. Local staffing, peer support, and mobile outreach can help reach underserved populations and build trust in the community. By making service accessible and the community drive, we can close the treatment gap and prevent new infections. South Africa experience holds lesson for other countries, especially those with generalized epidemics or complex social determinants. One major takeaway is that science alone is not enough. Policies, community engagement, and trust are essential. Countries that combine biomedical tools with social solutions are more likely to succeed. The story of South Africa is not just one of crisis, but its resilience and advocacy. In conclusion, South Africa has made impressive progress in the fight against HIV, but big challenges remain. High prevalence, structural inequality, and stigma continues to limit this process. However, with strong partnership, community-based models, and holistic care strategies, epidemic control is possible. As public health professionals, we must advocate for solutions that are both scientifically sound and socially just. Thank you for watching. I have listed here all reference at the end of this presentation. In the speaker notes, please feel free to reach out if you have any questions or feedback. And most important, let's continue working together to build futures where HIV is not longer a public health threat, but a chapter in our goal story of progress and compassion.